Hello and welcome back to Synapse. This is Ritika and today we'll talk about myocardial infarction or heart attack. It is a necrosis of heart muscle resulting from ischemia. This happens because of acute coronary thrombosis. Normally, there is presence of some atheromatous plaque which undergoes rupture, ulceration or hemorrhage, which leads to thrombosis and or spasm, which finally leads to infarction. Now, this infarction could be transmural or only subendocardial. A person suffering from heart attack experiences severe crushing type of chest pain or the pain in retrosternal area, which radiates to the neck, jaw, left arm and the epigastric area. And they also commonly present with Levine sign, that is they hold a clenched fist on the chest, which is due to the pain that they experience in the chest. There is something known as the silent MI, where the patient does not feel any pain. This is seen mainly in diabetics and in some elderly patients in whom we see autonomic neuropathy. The other clinical features are diaphoresis, weak and rapid pulse, dyspnea, and nausea. Talking about the diagnosis, first we have the ECG, where we see changes in the Q wave, ST segment, and the T wave. Next, we can look at the cardiac enzyme levels in the serum. The first one is myoglobin. Myoglobin is the first enzyme to rise in the serum and also is the first enzyme to go back to its normal level. But the problem with this is that this is not specific to MI. Next, we have creatine kinase. We have three isoenzymes of this. We have CKMM, CKMB, and CKBB. CKMM is seen in skeletal muscle, while BB is seen in brain tissue. CKMB is what is seen in cardiac tissue, and thus, rise in serum levels of CKMB isoenzyme is indicative of MI. But again, this is not completely specific, as CKMB levels rise also in conditions such as myocarditis, that is myocardial inflammation. Next, we have cardiac troponin. In this, we have troponin T and troponin I, both of which are raised in the case of MI. But troponin I has more relevance or importance in diagnosis of MI. Next, we have lactate dehydrogenase enzyme. Again, in this, we have two isoenzymes, which is LDH1 and LDH2. Normally, LDH2 is seen in much greater quantity than LDH1 in serum. But in myocardial infarction, we see that LDH1 is greater than LDH2. The histopathology of the cardiac tissue which has undergone infarction is very high yield for us to know. So within 4 hours of infarction, we see that there is no cardiac change as such. In 4 to 24 hours, we see intracellular edema and there's waviness of the fibers. 1 to 3 days, we see coagulative necrosis, neutrophilic infiltration, and infarct has yellow border, and that yellow border is because of neutrophils. 3 to 7 days, we see that there is increased amount of macrophages and monocytes which are coming to the area, and the neutrophil count over there is reducing. 7 to 10 days, we see fibrovascular granulation tissue. 4 to 6 weeks, a collagenous scar is formed. Just to mention a few other methods of diagnosis of MI, we have TTC staining, which is triphenyl tetrazolium chloride staining, where the infarcted tissue stains pale or yellow, while the normal tissue stains brick red in color. And thallium scan. So thallium, like potassium, is present intracellularly normally, but when there is myocardial infarction, because there is myocardial cell injury, we see that thallium leaks out of the cell. So looking for thallium outside the myocardial cells gives us a hint about myocardial damage. Well, when a patient with heart attack comes to you, all you want to do is to lead to reperfusion of the ischemic area so as to decrease or minimize the area of damage. But in a few patients, this might not really be so helpful because reperfusion in a few patients may lead to much greater injury or damage to the tissue than that would occur without it. This happens because there is sudden rise in WBCs which are flowing into the area, so which may block the microvasculature, leading to no reflow area or no reflow phenomenon. And also they elaborate a few proteases which causes myocyte damage. And now that there is sudden flow of the blood, there is increased production of free radicals in that area, which leads to increased myocyte damage again. And also the most important thing is a sudden rise in calcium levels, which leads to hypercontracture of the myocardium, which leads to contraction bands. Talking about the complications of heart attack, first we have the arrhythmias. Very commonly we see bradyarrhythmia when there is ischemia of the SA node. And ventricular fibrillation, it is a cause of mortality in a good percentage of patients with heart attack. We see arrhythmias here that is because of the very simple fact that damage to the myocardium brings about conduction errors. Or we could have cardiac rupture, which normally occurs within 3 to 7 days after infarction. The cardiac rupture could be of three types, that is, three areas where it normally occurs. So first is in the free wall rupture, where the left ventricle bursts or ruptures on its free wall, which leads to the blood entering into the pericardial space, which may lead to cardiac tamponade, which is very fatal. Next, there could be interventricular septum, which ruptures. If that happens, there will be shunting between the left and the right ventricle. And next, we have the mitral regurgitation that may occur. That could be because of the papillary muscle rupture. We could also see ventricular aneurysms as one of the complications, where a part of the ventricular wall becomes weak because of scarring. Now, that part may undergo aneurysm. Now that there is a separate pouch, that is aneurysm of blood which is caused. Now, the blood in the area may undergo clotting, or this aneurysm may further rupture. And if this rupture occurs maybe in the pericardial cavity, it may lead to cardiac tamponade. It may also lead to cardiac failure, which could be because of contractile dysfunction. Now that there is ischemia of a part of the myocardium, the contractility and the conductivity of that area is hampered. So that may lead to cardiac failure. Here we are done talking about myocardial infarction. I hope the video helped you. If it did, like the video, share and subscribe. Thank you.